Thanks everyone for coming.
That's right. Good.
Thankfully, we have Dr. David Harter with us today. So I'm going to disappear and just kind of let you introduce yourself, talk a little bit about how you got involved in this kind of work, and review your presentation. I'll come back later on to do all the questions and answers.
Great. So I'll probably try to do this in about 15 or 20 minutes because I know people have questions. I got some great questions ahead of time. I really appreciate the time that it takes to do that. And I appreciate the invitation to join the group tonight. I listened in on one of the other sessions and I really found it inspiring and interesting to hear the patient's perspective in such a kind of detailed and unguarded way. So I do appreciate the opportunity. I am in academic practice at NYU. I'm the chief of the division of pediatric neurosurgery, and I'm also the program director for the residency. So I help train the next generations of neurosurgeons. So it's something I really enjoy. I have no disclosures, there are no conflicts of interest for the talk. About me, I do pediatric and adult neurosurgery. So most of my adult practice involves congenital conditions such as Chiari, tethered cord, other things, colloid cysts, things that are amenable to endoscopic treatment. So that includes hydrocephalus. 90% of the practices in Manhattan at NYU, smaller portion at Bellevue. Then we do some work at NYU Brooklyn and Lutheran, Maimonides, and then we also have affiliation and active practice at Long Island, at NYU Long Island, which used to be known as Winthrop. I have two partners currently, Teresa Hidalgo on the left, Jeff Wissoff in the middle, and then we have a new partner joining us in August, Christina Saris, who's going to also be interested in Chiari and congenital malformations of the brain and spine. I really enjoy the clinical aspect of neurosurgery, the ability to communicate complex problems, and to find solutions that are durable, effective, and hopefully don't put too much of a hitch in people's routine and life and disrupt things. Just enjoy teaching what we do. We're also involved in research, both just at NYU and also collaborative research, including research on Chiari with a number of other institutions, and advocacy. I've been a member of the Hydrocephalus Association Medical Advisory Board for about 10 years, so I'm interested in also steering the ship and kind of deciding where things are best addressed. The picture up on the right is my great-grandfather. he was a vaudeville type performer in Europe, so there he has his psychic dog Caesar spelling black and white, which he's holding behind his back so Caesar doesn't see it. I never met him, but sometimes I feel like I'm doing a similar magic trick with what we do. I'm going to talk a little bit about generally how best to approach a visit with the doctor and how to prepare for it. Your doctor is going to be appreciative if when you come in you have everything organized. She'll know what you want to get out of the visit. I think that's important. So if you fail to prepare, you prepare to fail. That's attributed to Benjamin Franklin. And that begins with choosing who you're going to see. So you have to vet the practitioners who are going to be involved in you. Some people are limited geographically. You may not have as many choices, but it is still important to do your best job to find someone who is familiar with your problem and is interested and enthusiastic about taking care of it. What are the goals for the specific visit? I think it's really important to get that in your head before you go. What do I want from this visit? Is this a decision whether we need to operate or not? Is this a decision about what activities I can do? Is there new medications I can try? Writing it down helps because you don't forget. It's super inconvenient to go to a doctor's appointment. You have to park, you have to find daycare, you have to take off from your job. And I'm very aware, particularly in a place like New York, what an encumbrance that is. So I want to make sure people get the most out of their visits. One thing you do is consider a checklist. So as the items are addressed, you can check them off, and that way you won't miss anything. And bringing a family or friend can be really helpful because sometimes it's emotionally charged and the stress, and you just don't remember things, and you can turn around and ask that person, did I hear that right? Or even that person can pipe up and ask questions or remind you about a symptom or a piece of history that you wasn't at the top of mind. I think it's also helpful to have all the useful documents and tests. So that allows people to make decisions while you're there instead of I'll get back to you and then playing phone tag and then messages, and that's frustrating for everybody. The other thing is don't be afraid of a second, third, or fourth opinion. If you have a complex problem that's going to impact your life or the treatment might, I think it's important to consider other opinions. At the School of Medicine, we have this thing about our approach to things, and that's pride. So performance, so accountability, driven, and dedicated. So Are you going to be around when something happens? Are you going to take responsibility for it as a practitioner? I think very important. Respect. Are you empathic? Is your doctor, oh, sorry, is your doctor open to alternative suggestions or input or ability to change course if something different happens? And integrity speaks for itself. Diversity, are you being treated as everyone else should be? So, practitioners should approach everyone with equanimity, regardless of race, creed, financial situation, anything, language ability. So I think it's important to recognize that that's an important part of anyone who's going to be taking care of you. And you want excellence, people who are tenacious. If there's a problem, they want to fix it. If I have a complication, I want to be like a bulldog and figure out how to solve it. And resilient, you have to be able to get up and take care of problems. And I mentioned it a couple of times, but passionate is a person interested in your problem. And what this results in is then you and your colleagues may have a good standing in national rankings, and it's not an accident. It's not the only thing, but it's good to know. Another thing we're thinking about when we're going to take off on any treatment choice is primum non nocere. So this is kind of an old Latin phrase that says first do no harm. And how do we do that? So intervene only when we know that the diagnosis is accurate. We're sure we're treating what we think we're treating. And then with the patient, we have to define what's the most effective treatment with the least risk. That's the whole game in the office, is figuring out how can I get this person back to how they want to be, or as close to that as possible, while incurring the smallest risk. So we're talking about individualized care, of personalized medicine. So for me, that means I'm going to make a recommendation, but ultimately you're going to make a decision. And as long as that's a reasonable decision based on, good science and good intuition and good judgment of an experienced practitioner, that's a good way to go. The specifics of your or your family member's situation. So that's anatomically and physiologically what's going on. What other problems do you have? Do you have heart problems? Do you have lung problems? Is anesthetic risk high for you? Is it low for you? Are there certain genetic things that we have to keep in mind? Is it part of a syndrome that we know to look out for other things for? And what is the patient going home to? Do they have adequate social support? Are they going to be able to get physical therapy? Are they going to be able to get the medications that they need? It's important to know before we start something that we're going to be able to finish it in a way that we want to. And how does the treatment fit into the patient's and family's plans? School, employment, avocations, what do you like doing? Are you going to be able to do that again, and when? And goals and expectations. So as a practitioner, we have to be able to, along with the patient, verbalize what we expect to happen, what our goal of treatment is, what's reasonable, what's rational, what's possible. And I think it's important also to say what we know for sure and what is based on experience or intuition. Those aren't invalid, but a scientifically generated decision may have more weight than what your practitioner, just has from experience. And the golden rule versus the platinum rule. I don't know if anyone's heard of the platinum rule, but the golden rule everyone knows about. It's treat everyone how you would like to be treated yourself. I recently came across the concept of the platinum rule, which is even better. Treat the person as they wish to be treated. So I'm not making a decision how you want to be treated. You tell me how you want to be treated. What are good questions for those visits? I think these are ones that I've all had over the years, and I've come to appreciate them. What would you do if you were the patient, or if this was your child? What would you do? That involves a bit of empathy and reflection, and I think it's good to have that. How often do you do this? Is this a very rare problem that you never take care of, or is this a common problem? Do you take care of a lot of it? Because generally volume correlates with outcomes. The more you do of something, the better you do it. When someone quotes statistics, are those from published literature, or are they from your own? And how do you track it? Have your statistics been published and peer reviewed? It's just a way of knowing the veracity and the significance of it. What are the most common difficulties you've encountered when treating this problem? What's the typical post-operative course, or what's the typical course without surgery? What do you project the natural history to be? And when do most patients return to their usual activities? So these type of questions, I think, are very helpful to have. It, number one, alerts the physician that you know what's going on. You're sophisticated, you're aware of it, and you have a goal of getting back to where you want to be. In terms of Chiari, what leads to successful surgery? So this is one of those conditions where it's critical that you select the correct patients. If you have patients with migraine, typical migraine, you operate on them because they have a Chiari malformation, there's a significant chance they're not going to get better. Whereas if they have tussive headaches in the occiput, back of the head when they cough, that's much more likely to get better. There you're in the 90, 95% kind of range, assuming there's no other disorder underlying. Early treatment for syringes or syrinxes. I still don't know which is the proper way to pluralize it is. Either syringes or syrinxes, and I'm open to suggestions for that. And consistent technique. So if you're doing a type of surgery, it's important to do it the same way so that you know what the results are. You can't change things on the fly unless there's extraordinary circumstances. Another thing specific to Chiari is we take the bone off. Everyone's going to do that. We do probably a C1 laminectomy. Do you do a duroplasty? As that is, are we going to open the dura? Are we going to make sure there's outflow from the fourth ventricle? There's pros and cons to this, and this is a great example of something that I really like to go over with the patients and families, because there's some patients where I'm really in favor of not opening the dura because I think there's a very high chance that they're going to get better. If it's a patient with tussive headaches, no syrinx, and no other red flags, I may be very, very comfortable just doing bone only, and most of those patients are going to get better. And if they still have problems, we can reevaluate it. But I think it's a great way to start. It's a smaller operation with a much smaller risk profile. So the advantages of doing duroplasty are some patients note increased symptom relief. There's probably a higher rate of syrinx resolution, and it happens probably quicker than if you don't open the dura. And there's a decreased rate of operation, but we know that it's not a free ride. Open the dura, do a patch, you could have a leak, you could have bacterial meningitis, you can have aseptic meningitis, a little more blood loss, you can have pseudomeningocele, hydrocephalus, and longer hospital stay. It's not unusual for patients to go on and off steroids after duroplasty because they have a little bit of inflammation and stuff. Here's an example of a case from recently. So this is a 40-ish-year-old woman who has pretty pure tussive headaches. She has headaches that are just in the back of her head. She has some other symptoms that are not so clearly related to this relatively moderate Chiari. This is the tonsils down to C1, so it's about 1 centimeter of tonsil descent. There's no syrinx. She has tussive headaches, but she also has a couple of other things that aren't unusual. She has tinnitus, and she has some vertigo, which I'm sure to a lot of people in the audience, this is going to be a familiar constellation of symptoms. But if we do bone only, or if we do with duroplasty, I can't guarantee that tinnitus is going to get better, and I can't guarantee that vertigo is going to get better. So we do the bony decompression, and then we look with the ultrasound, and we make sure that things are pulsed up. CSF is moving back and forth. The cerebellar tonsils are flopping around. There's choroid plexus going in and out of the fourth ventricle. So I'm convinced that this is good. This is the line of the dura right here. This is CSF. This is the spinal cord, and this is the cerebellum. And I'm convinced that this is adequate for this patient's problem. Tussive headaches, much better. Tinnitus, interestingly, went away quickly in one ear, and we're waiting for it to go away on the other ear. So it's kind of interesting. This is another boy where we did things a little bit differently. So he has kind of plump ventricles. He has not the big worst Chiari, maybe 5 millimeters, just barely meets the criteria. He's got this kind of edema in the upper cervical cord, and he's got just about a holocord syrinx with scoliosis and other stuff. So I was a little worried he might have a leak or something after surgery if he has hydrocephalus. If this is hydrocephalus versus maybe slightly increased baseline intracranial pressure, that if we do a suboccipital decompression, he's going to get a leak. And I talked to the parents about this, and I said I was concerned about it. And oftentimes when we see this, we'll just treat the hydrocephalus separately. They said they don't want 2 sessions of anesthesia. They would just want to make sure it's done. So we did an endoscopic third ventriculostomy first, which is a treatment for the hydrocephalus. And then we did a suboccipital decompression, same sitting, just based on the family's preference and discussion. So then, within about 5 months of surgery, this is the posterior fossa. It's well decompressed. There's kind of a new cistern here. There's plenty of room for the cerebellum. The edema in the cervical cord is gone, and we're kind of just left with a little bit of a syrinx, which is much smaller. But interestingly, his ventricles, the brain fluid didn't change at all throughout that. Symptomatically, he was better. He was having tussive headaches. He was having dysesthetic pain related to the syrinx, and that all got better. Some of the pitfalls that I've seen in taking care of Chiari malformations. So I think on the way in, you have to be very, very careful to avoid a couple of other diagnoses. So a couple of questions that were submitted included questions about idiopathic intracranial hypertension, also known as pseudotumor cerebri. So how do we kind of look out for that? preoperatively. So there are a few demographic features. So we know that patients with elevated BMI are certainly at risk for that. Patients who are on certain medications are at risk for that. And then there's going to be clues on exam. So we're going to look at the fundoscopic exam. Is there papilledema? This is an example of a fundoscopic picture where this is the disc of the optic nerve, and this should be very flat and sharp, and it's not. It's blurred. There's venous congestion. There's pressure transmitted to the eye. The other clues on MRI would be tortuosity of the nerve, uh, um, bump on the optic nerve head, and then engorgement of veins around the optic nerve. And then the other thing that we might see is empty cella. So this is a midline sagittal MRI scan. You can see on this one, this is a normal pituitary gland, kind of looks round. And on this one, it's all just a crescent. That bright spot is the posterior pituitary, and this flattened part is the anterior pituitary. This is the pituitary stalk, but this is an empty cella turcica. There's no obvious pituitary, and this is related to transmission of pressure from the brain and fluid into the pituitary gland. So that's a big one that I'm really careful about. Those patients generally require either medical management, so diuretics, serial lumbar punctures. You can consider for patients with elevated BMI weight loss strategies, including the newer medications, or even bariatric surgery. So that's something that we'll discuss if this appears to be the problem. The other thing is acquired Chiari. So you can get an acquired Chiari malformation related to leakage of CSF from somewhere else, a dural tear or a diverticula along the nerve root, or even increasingly recognized CSF venous fistula. So here's just examples of that. So here's diverticula along a nerve root sleeve. Here's like a little bone spur leading to indentation on the dura, wearing down, and then there becomes a connection between the vein and the dura. And here's a vein. Pardon me. This one's just a leak of CSF. This one's the connection between the CSF and the vein. This is increasingly recognized as a problem. Chiari 0. So tonsils don't have to be down. You just have to have fourth ventricular outlet obstruction to get a syrinx here. And this is diffuse meningeal enhancement related to low pressure. So usually there's going to be clues about this, but we all get kind of fooled once in a while. So it's important to ask about the onset of the Chiari and symptoms. So now I'm going to zoom out a little bit, broadly pitfalls that you can get into. So overvaluing like a new technique over something that's been around for a while that works just fine. So people try to like make modifications of existing techniques or do something a little bit different to either bolster their academic credentials or to generate more patient interaction and more surgery. But new isn't always better. There's a lot of good solutions for a lot of the problems. Everything looks bigger up close. So if you're in the middle of like a crisis with pain or something, the problem can seem really critical and you might want to do something right away, but sometimes taking a little bit of time to reflect is good. Don't believe everything you hear or read. So the internet age, you have to be really careful about what's out there. Is it a reliable source? Is it just one person? Does someone have an axe to grind? Is someone disappointed with what happened to them and they have an axe to grind? Or sometimes people are quite sincere in what they're saying, but they just don't have a big enough view of the field or of the situation to understand it. And don't overly rely on a single data point. So one piece of the puzzle may not give you everything. So it's in this setting, Chiari can be responsible for a lot of problems for sure, but the temptation is if a patient has a bunch of issues, so headaches. So headaches, sure, Chiari can cause headaches, but is it the right type of headache? Or do you have more than one type of headache? You could have typical tussive headaches combined with frontal tension headaches or migraine. And so some of the headaches may get better, but not all of them are going to get better. So it's important in decision making not to hang our hat on it. It is a big temptation. And I've seen not just patients, but also doctors fall into this. As far as unanswered questions for this, we talked a little bit about duroplasty versus not. Which patients with minimal symptoms will not progress. So there's probably a group with either a small syrinx or minimal symptoms that will either be stable or wax and wane over time, and it may not be worth the risk of surgery, even though it's not a particularly risky surgery. Which patients with incidental Chiari will develop symptoms? Probably not many. Should we have surveillance on those patients? Not sure. And which patients with atypical presentations may benefit? So this is things like tinnitus or vertigo, or maybe like a little extraocular movement problem or something. Are we operating on too few patients? I think it varies practitioner to practitioner. The other thing is there's stuff we just don't know. So these two slides that I'm showing, because I wasn't taught this in medical school. This wasn't out there 20 years ago. So the diagram on the left shows that brain fluid flow switches direction in deep sleep. I would never imagine this. So flow in the fourth ventricle goes forward when you're sleeping, backwards when I'm sorry, forward when you're awake, backwards when you're sleeping, and that's also connected to neuronal activity. The idea of this, I would have told someone that they were crazy if I'd heard that 20 years ago. The one on the right shows this a concept of the lymphatic system. So this is a connection between the CSF going through the brain, circulating, going around the veins and into the lymphatic system. And this connects also to the papilledema that I showed. And also like families and patients will say, I'm puffy around the eyes when my symptoms are worse. And this may be one of the mechanisms for it. I think it's important to recognize that there's stuff that we know for sure, stuff that we don't know, but then there's a whole group of things that we don't even know we don't know. It sounds confusing. Just showing these pictures, this is just fun. So here's 4 of our residents. They all happen to be women, which I really enjoy. Help train in the next generation. Everyone's smiling, so we like what we do. This is the whole cadre of residents here, and it really makes it fun to pass our enthusiasm on for and passion for taking care of our patients and solving puzzles together. It really it brings out the humanity in things, and I'm glad that I can pass on my philosophy to this group of talented people. So that'll be that for my talk. I do thank you for your attention, and I would like to open it up to questions. I can either go through the list that I was given, or we can allow people to answer. I'm open to either approach. So thanks for your attention.
Thanks. It's taking a second.
A stunned
Thank you.
silence comes over the audience.
Sorry, my computer's just a little slow. I want to apologize because I think people are having audio issues, so I am sorry about that. But
Did you hear me?
I can hear you, so I'm assuming the recording will be fine.
Okay.
So to that point, though, I mean, we can just start going through some of the questions.
Okay.
The first one is a good one to start with. Actually, I kind of want to do one that came up in the chat really quickly because it's relevant to kind of the pitfalls that you were talking about. Is there a reliable way to quote unquote rule out some of those pitfalls, either before surgery or maybe someone's already undergone something like a fusion and now what's the steps? How do you rule out those other things without really just draining your energy and doing all that?
Yeah, I think that's a really good question. I think the number one thing is listening to the patient. So oftentimes, like this is one thing we kind of teach. Listen to the patient, let them talk. How did things start? What was the story? Was it trauma? Was it like childbirth? Was it an accident? Or was it like a slow, gradual thing? I've always had these problems, because there's going to be clues there. And then the second part of it's going to be a physical exam. Are there going to be any things that, lead you one way or the other? So the biggest one is like that papilledema that I showed. If there's, swelling on the eye nerve, it's very unlikely to be primarily related to Chiari, unless the Chiari resulted in hydrocephalus. But then you don't even know if the hydrocephalus came first and the Chiari is acquired, or if it's chicken and the egg situation. So it can be difficult to tease out. And I would say that the vast majority of these things would be figured out by, again, history, physical exam. Then we got to look at the imaging. So I showed a couple of examples of like empty sella and hydrocephalus and other findings related to elevated pressure. I think that's very helpful. So I've scrutinized that first MRI because the treatment's totally different, as we discussed. It's either the medical management of intracranial hypertension, or it's a shunt, not posterior fossa decompression. So that's going to be important. You can go to things like intracranial pressure monitoring, lumbar puncture. That's going to help sort out a lot of it. And a good neurologist may be able to help tease some of this out, but in my experience, the neurologists aren't quite as helpful as the neurosurgeons in teasing it, because the neurologist is not doing the operation, so they're not as invested. If I'm going to do an operation, I want to make sure that I know what the story is and I'm doing it for the right reason. So really good question.
Yeah. And to piggyback off it a little bit, one of the questions that came in ahead of time, I'll jump to the end. It was more of like an advocacy question. Especially in the emergency department, So there are, like you're saying, there are just clinicians that are a little bit less invested in doing that kind of stuff. So how, if someone, especially in the setting of previous hydrocephalus, they had a shunt
Right.
placed, how can a patient advocate for themselves in that emergency department, and if they're having an emergency
Yeah.
situation, what do
This
they
was
ask for? How do they get that monitoring that they probably need?
Yeah, so that was a really good question. I like that one. Someone went to the emergency room, they've been treated for pseudotumor with a shunt, and the imaging is unchanged. The imaging is always going to be unchanged because the ventricles aren't going to change size. They seldom do. And there's a false sense of security because the reading from the CT scan comes back, ventricles are normal, there's no hydrocephalus. Well, I didn't have hydrocephalus in the first place, and if you go back and look, I've never had big ventricles. So that's an important part to say it. You can say explicitly, in my condition, shunt malfunction is not manifest with enlargement of the ventricles. Can I have an ophthalmologist please come and check my fundi to see that I don't have papilledema? That's a good one. You can always do a lumbar puncture to get pressure reading. So that's a quick one. So that doesn't require any surgery. It's a procedure for sure. And then the other things you can do are things like a shunt patency evaluation, where it's a nuclear medicine study where they inject the shunt with dye and see how quickly it runs down, and that confirms patency. So I think that's an important part of it. In my experience, patients with idiopathic intracranial hypertension or pseudotumor can have a functioning shunt and still have headaches. The headaches are multifactorial and can be really difficult. So a shunt patency evaluation in that setting can be really helpful, where they just inject, measure how fast it goes, and that tells. So I think you have to, your practitioners have to be willing to listen to you. Right? I've learned a lot from my patients because I try to listen and I understand. If you try to brush people through things or get them out, doesn't help. Sit down, listen to the patient. Usually the answer is there. Sometimes you have to advocate for yourself. Say, I'm not leaving until an ophthalmologist tells me I don't have papilledema. I'm not leaving until you do a shunt flow study. What's your name? those are good approaches to that. But I think you say I understand what you're saying. Most of your patients, there's going to be a change on CAT scan. In my particular condition, there's not, and that's okay.
Yeah, that was a great answer, actually. Thank you. And then I'll get to some other questions. This was the first question. What is cerebral perfusion? How is it related to intracranial pressure? And then how does high blood pressure impact?
Good. I love it. A great question. So this is good. So here is. You see the slide?
Oh, I took it down. I'm sorry. You know what? I'm gonna turn my camera off because it's getting a
Yeah,
little
that's
glitchy.
fine. No problem.
And then
So,
you can share again. I apologize.
okay. This is oh, I have to share again.
Yeah.
Yeah, sorry. I have a couple slides pertinent to this because you guys gave me the heads up. I loved it. I was able to put a couple slides on. That was really terrific. So what this is showing is this is intracranial pressure on the y-axis. So 0 is normal, 10 is normal, 20 is kind of normalish, right? And on the x-axis is we're adding volume. So this could be anything. So this could be CSF, it could be brain, it could be blood, it could be whatever, any tumor, right? So anything can cause that. But what happens is we have ability to accommodate that for a certain amount of time or a certain amount of volume, after which this curve becomes very steep. So you can accommodate another 10, 15, 20 cc's, and particularly if it's happening slowly, you can accommodate that. But at a certain point, you're just adding so much into the skull that the pressure has to go up. You can't get rid of more spinal fluid, you can't displace venous blood, you run out of space. So here the pressure starts going up very quickly, and this is where we got to do something. So there's a certain point where intracranial pressure overcomes perfusion pressure, so the blood pressure. So how much are we getting? How much blood is getting into the brain? Oh, sorry, are you seeing?
Mm-hmm.
Are we seeing it?
Oh. Yes.
Okay, sorry, I'm a little, because I have a window here. Not now. I don't want to not now that. I can minus that. Okay, sorry. I'm playing Windows here.
No worries.
Sorry. Try to make that small. Okay.
Tech.
What? Anyway, so can you see it over here?
Yeah, but it's just not in what's that called? Slideshow mode. That's all.
Yeah. Let me try to do that.
if it matters. I mean,
But yeah, no, I don't, because now I can't see it.
there
That's it.
you
You
go.
can see it? Can you guys see it?
Yes.
Yes.
Okay. All right. So yeah, sorry. That slide showed like over on the right, the pressure in the head is getting higher than the mean arterial blood pressure, in which case you start not being able to get enough blood into the brain. And that's where you get symptoms of problem. Can we see this too?
Yes, hypoperfusion and
Yeah.
these are
So what this is showing is what we do in response to systemic blood pressure. So the brain has the ability to regulate how much blood goes in and out, right, based on the metabolic demands. So at low blood pressure, the spigot is open all the way to get as much blood in as possible, right? Because we want to maintain all the oxygen and blood supply to the brain. So the brain opens everything up, right? The faucet's all the way open. And over a wide range of blood pressure, it can keep that constant. Over a certain point, you start breaking through that. So even if you turn the spigot down, the flow is still way too high, and then you're unable to regulate the blood blood flow versus the intracranial pressure. So this is like hypertensive crisis when someone's blood pressure gets so high that it's causing the brain pressure to go up too, and that's when you can get at risk for stroke, hemorrhagic stroke, and other problems. So I hope that explains it. It's a little bit of a tough concept, but I hope that got to it a little bit. So yeah, you add stuff into the brain, into the head, the pressure goes up. The blood pressure over a wide range of values maintains perfusion pressure as needed. When the blood pressure gets way too low, you can't do that. You get ischemic stroke. When it gets way too high, you may have breakthrough and get hemorrhagic strokes or hypertensive encephalopathy or other crises. Good?
yes. Thank you. And then excuse me. One of the other questions that came in is sort of relevant to this, so I'll just ask it next. They were told that their Chiari was brought on by that pressure, so pressure issues. The ICP showed pressure 40, 36. Frankly, I don't, but it doesn't stay high long enough to be considered, I guess, pathologic. Then a CT was done the same day showing like a ventricle that was partially compressed, whatever that means.
Yeah.
So they're not really sure it's a chicken or an egg thing. What do they
Yeah.
treat first?
Right. So eye exam would be critical. So that would be a fork in the road. So if the pressure is high, you need treatment for pseudotumor idiopathic intracranial hypertension. It would be important to know if the ICP was, when you mean transiently, you mean like when you coughed, sneezed, bent over for like a minute or two, or was it 40 or 30 for 6 hours? So those would be very important distinctions for me. If you had a Chiari that's symptomatic and your pressure is transiently 30 or 40, we could probably just treat you as we would treat any other patient with Chiari. But if it was sustained 30s and 40s, I'd be more concerned that there was an underlying ICP issue that was causing the Chiari.
Sure. Good point. One of the other questions that came in earlier was about syringomyelia, and they're asking if it's hereditary, and if so, how are children born with it? Do we know why that ends up happening?
Yeah, so the vast majority of cases, patients with syringomyelia are not genetic. I would say the most common setting where we see syringomyelia in an infant would be those with tethered cord, either myelomeningocele or lipomatous malformation of the distal cord, rarely from like hydrocephalus or Chiari. I can't remember a newborn or infant with Chiari and syrinx that early on. I'm sure it's out there, but they tend to present a bit differently. But that's a good question.
Mm-hmm. One of the questions in the chat was, I've never heard of this one before, so this will be fun. What is the significance of cavum septum virgae
Yeah.
in a patient with Chiari 1 and syringomyelia with severe symptoms?
So that is one of the what we call a midline fusion defects. So we all have this very thin membrane that separates each of the ventricles or the fluid spaces in the brain. That's called the septum pellucidum, and that cannot fuse for a variety of reasons. Usually it's asymptomatic, doesn't cause problems. Rarely it will get big or expansive and cause headaches, in which case we can just fenestrate it endoscopically. But usually it doesn't need treatment, and unless it's associated with other congenital anomalies of the brain, usually it doesn't impact development. But you're describing here someone with cavum septum, Chiari, and what was the other one?
Syringomyelia.
And syringomyelia. So yeah, I don't think it would impact necessarily the treatment for the Chiari or syringomyelia, unless really it was shown to be in play with some CSF dynamic or clearly symptomatic or clearly changed over time. I would imagine I would probably just treat this patient as if they didn't have that, unless it was separately symptomatic.
I wanted to get to the hydrocephalus question that came in earlier, because basically it was asking what is it, and then specifically what is known about neuroendoscopy for its treatment. So I don't know if you can speak to that.
Yeah, so hydrocephalus simply is a mismatch, in the simplest explanation, is a mismatch between the amount of CSF or spinal fluid that we make, which is almost like water. It has a little bit of sugar, a little bit of salt, but it's really close to water. Mismatch between how much is made and how much is absorbed. And that could be either on the basis of a blockage of how it's getting absorbed or circulated in the brain, or being overproduced. Overproduction is probably very, very uncommon and is usually related to tumors of the choroid plexus, which are very, very rare, and you would know if you had it. So most of the cases are due to obstruction. The role of endoscopy is big. So if you have an obstruction within the ventricular system, most of the patients can be treated successfully with an endoscopic procedure, usually endoscopic third ventriculostomy, where we make a hole in the floor of the third ventricle and let the fluid get out before the obstruction to the space where it gets absorbed. The other thing that we use it for is placing shunts. Sometimes it can be helpful in ensuring accurate placement of a shunt into the lateral ventricle or to another CSF space that we want to get to. And then occasionally it's useful for diagnosis if someone has something going on in their ventricle and we don't know what it is a tumor, is infection. We can do a biopsy at the same time. So that could be helpful as well. And I think that's probably the main role of endoscopy in hydrocephalus.
Perfect. Thank you. This was interesting. I didn't think about it before this question came in. Could something anatomical like a pineal cyst cause some intractable treatment resistant, they say anxiety and depression, which I thought was really interesting. I don't know.
Yeah. Well, we know, it's involved in sleep-wake cycle for sure. And there probably are effects that we're not 100% aware of in other species, like some reptiles. Is very important in sleep-wake cycle and other things. But in humans, the role is not quite as clear. There probably is some function, but by way of example, there are patients with pineal region tumors or cysts, and we end up taking the pineal gland out along with those. And I'm not aware of any specific syndrome related to that or any need for like any hormone replacement or whatnot. So I would say I'm not aware of any defined relationship between that and the described symptoms, but could there be? Absolutely.
Sure. Thank you. This is going to come up in a bit, so I'm going to ask this question first. What's the connection between syrinx and scoliosis, and is this something that someone should be worried about in their children?
It depends. So I would say there's a wide spectrum of things that we see in kids with scoliosis. So probably the most common thing that we see when a patient is referred with scoliosis and quote a syrinx is that they don't have a Chiari malformation and they have a very, very minor syrinx. And I would really almost call it like a persistent central canal. It's a normal anatomic structure that just doesn't go away. That's probably the most common scenario. And no one knows for sure what the connection is, but my sense is that's a developmental disorder of the spinal cord itself. And it's probably an imbalance in the innervation to one side versus the other of the chest, thoracic, and abdominal muscles, leading to imbalance and kind of pulling or pushing the spine one way or the other and producing scoliosis. So that's kind of, I think, the most common scenario we see a syrinx or a prominent central canal in. There definitely is another significant subset of patients where there is a Chiari and a significant syrinx and scoliosis, and it's probably the same mechanism where the syrinx comes to involve one side of the spinal cord a little bit more than the other, and it can impact sensory function or motor function, leading to that same imbalance one side versus the other, and then curve, and then compensation of that curve at other levels, so you end up with that S-shaped curve. The distinction is that those curves related to syrinxes are usually more rapidly progressive. They can be dextroscoliosis, the kind of unusual way, and can be more difficult to treat. So in that setting, usually we'll treat the Chiari malformation first, see the syrinxes addressed, and then either bracing or posterior spinal fusion or other scoliosis surgery if needed.
Mhm. Then, is there ever a reason to do prophylactic Chiari surgery for a small syrinx?
For a small syrinx, okay, so they're small and then they're small. So
Interpret that as you will.
what?
I said interpret it as you will.
Yeah, interpret as I will, right. I think this is an individualized decision. This is where it comes in handy having like an experienced practitioner. So if this is a patient you're telling me didn't have symptoms, got a scan for some other reason, we'll say trauma or some weirdness. If this is a patient who can be followed reliably and the preference is for no surgery, I think that's okay. But that I would suggest a good practitioner who can follow up with a consistent neurologic exam. And I would probably be only comfortable if this patient had follow-up imaging at some interval, a year, 2 years, to make sure that it was stable or gone away. On the other hand, if this was a patient who I didn't know what resources they were going to have for the next 10 years, I probably would recommend surgery. From large groups of patients, we know that once a syrinx is there, usually it'll progress, but obviously there are exceptions, and I don't like to be dogmatic about it. We do know from large groups of patients who are asymptomatic, and Chiari has been discovered, a very, very small number of those go on to require surgery. It's probably on the order of 2%. So if we find it by accident, let's assume that the incidence of Chiari is 1% of the population. That means, one out of 100, every time someone comes in for a car accident and they get imaging, we're going to find one. And many of those patients are asymptomatic, so they don't get treated. But it's important to kind of figure out what the flavor of the particular patient's problem is, and then also this idea of what their access to medical care is and to skilled follow-up is, because I think that's going to play into it as well. It's the patient in their world. You can't just look at the scan and say this. It's
Sure.
more nuanced.
Yeah. I want to get to this other question that came in online, then there are two good ones in the chat. So, but first, could a post-surgical pseudomeningocele cause something like regular pain in the arms and legs?
It depends. If it was big enough to cause compression of the cervical medullary junction, maybe, but I wouldn't think that this would be a typical symptom from a contained pseudomeningocele. More common, I would expect, like positional headaches, local pain, those kind of things.
Mm-hmm. This is really interesting. In a patient with Chiari 1, obstructive sleep apnea, or narcolepsy, they develop syringomyelia and severe symptoms. What would you advise in that kind of a patient if they're non-responsive to the treatment of the narcolepsy specifically? Which is now
if you're medically fit, then I think those would be strong indications for surgery. The syrinx, and there can be some component of central apnea for Chiari. It's not the most common thing, but it can at least contribute. So I would say if the BMI is elevated, that getting that down would help both with the apnea for sure, and it would make surgery less risky. So I don't know if this patient specifically has an elevated BMI, but I would make sure that that's addressed if it is part of the problem first, because it'll make anything probably more effective. But if you're going to give me a scenario of Chiari, apnea that's central, and a syrinx, I would probably advocate for surgery in that setting.
Okay, interesting. And then there was a question about having pain, really, really bad pain, having to visit the ER level pain during car travel. So is there something that you would recommend in a patient that, I mean, if they're symptomatic with Chiari, syrinx, scoliosis, and degenerative stenosis, which I know is like a problem in and of itself.
Yeah.
Um,
Um,
yeah.
I would say if it's movement related and you're not the driver, you could consider some sort of orthotic to reduce neck movement. Because it sounds like maybe that would be part of it. Hard cervical collar, just see if that makes it better. As long as you're not driving and trying to turn around and see what's see behind you, I think that would be an okay strategy. If you haven't been treated for Chiari, it'd be something to think about. Going over your symptoms with someone who knows what they're doing would be good.
Sure. And then there are two questions that came in earlier that I do want to get to before we run out of time. First is headache symptoms persisting in pediatric patients after surgery. So what do you usually recommend they do to minimize those high pain days? And is there a general quote unquote threshold that you're going to use to identify if there's further surgery that might be needed?
Oh, yeah. Right. So I think this goes back to the patient selection. So, were these typical tussive occipital headaches, or was this another headache disorder? So that would be ideally figured out before surgery. So if this was typical tussive headaches and they were gone for a while after surgery and then they came back, that would be important to know, because you can get, particularly in kids, you can get reossification, or the bone can actually grow back if you take it out. Or if there was obstruction of the CSF from the fourth ventricle, that can scar down again. So it's certainly not something I'd run into surgery for again, but I'd really want to know more about the specific types of the headache. Obviously, getting a medical person involved, like a neurologist, for headache management would be great. One of the helpful things is to kind of keep a log and understand what are the specific triggers. Is it a specific activity? Is it specific food? Are there medications that tend to work one better than the other? And then there's just the obvious kind of hygiene things. Are you sleeping properly? Are you eating properly? Or you're not spending 8 hours on a screen? These kind of things.
Perfect. And then one other question that I did want to get to is especially relevant, and I think it's going to be different in peds versus adults, but how long do you think Chiari patients should be followed up after surgery? So at what point do you say you're good and you send someone on the way?
Oh, that's a great question. This is philosophical almost. Like, there's some doctors who just like to hold on to their patients forever and see them do everything. Part of what I enjoy about this is seeing my patients move through life and share their accomplishments, and hear about all their good stuff, their graduations, their awards, their weddings, their all that kind of thing. So I do like seeing patients, and I'll typically offer follow-up appointments until people stop coming, because it's kind of fun for me. But other people are very practical about it. And let's say we operated for headaches. My headaches have been gone for 2 years. I've had no surgical complications. I feel great. I'm not moving anywhere. I'm a reliable person and family and stuff. So that patient, if they prefer not to follow and we just leave it as needed, if new problems occur, I'm fine with that. But my general preference is to just give people appointments until they stop coming.
And then there was a question about, firstly, I'm not even sure. Do you see adults and pediatric
Yeah, so
patients,
one of
or
the good
just the
things,
adults?
yeah, one of the good things about my practice is that we have a children's hospital within a hospital. So there's 2 floors that are just pediatric, but the rest of the stuff is adult. So I operate in the neurosurgery ORs, not like the pediatric surgery ORs, which is great. And therefore, in the office and in the hospital, I can take care of adults and children. So I'll take care of kids, from when they're 2 to when they're 92, the Lord willing. Yeah, and that's part of what I like. So yes, I follow patients from childhood into adulthood, and I also take care of adults when they're all grown up too.
And then this did come up, and I actually am not sure how this is going, and I don't know if you can educate me on it. As far as the telemedicine regulations,
Yeah,
you see patients by telemed, and then
yeah,
how long do
we
you
do.
think that's going to be a thing?
Yeah, no, I think it's not going away, and part of what I was mentioning earlier was the inconvenience of appointments, the stress of
Mhm.
appointments. By the time you get to the doctor's office, you're like paid for parking, my kids in daycare. I'm out of work for a day. It's a huge disruption. So I think there are some things that we can offload uh, using telemedicine, and I think a few examples are great. So many routine follow-ups can be handled with telemedicine. So I had surgery a couple weeks ago. I just need you to look at my incision, go over how I'm feeling, whatnot. Obviously, if there are any problems, I'm going to tell you to come in. But really, if someone's, right on track for recovery, I have no problem with, taking care of them while they're home. And actually, it's enlightening to me because I get to see where and how people live, which has been an amazing, amazing thing. You see the dogs, the cats, the mother-in-law, the son-in-law sleeping on the couch, the neighbors, dog bark. I love that stuff because it just gives you insight into what we're doing. So that's part. So I think that a routine follow-up is okay. I think as an intake is okay too. So if someone has a question, will you maybe be able to help me? I think that's good. Like if you send me the films and you want to talk about things, I don't mind that at all. But if we're going to be talking about surgery, I'm going to see you in the office. I'm going to examine you. We're going to do like a thorough thing because I think that's very, very important. But I can give you an idea whether or not I think you're a candidate for surgery by telemedicine. But if we're going to make a final decision and treatment recommendations, that's for the office. And then long-term patients, often if there's not subtle neurologic findings on exam that we're following, I think telemedicine is okay for that too.
And just as a follow-up, do you frequently see out-of-state patients? I know there are several, at least in New York City, several institutions that do. I'm just not sure how.
We do. Okay. There can be vagaries with, there's some regulatory issues, but sure. we take care of our patients that are interested in getting taken care of.
For sure. There was one final question that came in that I do want to get to before I ask how people can get in touch with you. But can you explain something like sudden loss of vision and speech in a high pressure episode? What would be the mechanism there?
Yeah, so that goes to that curve that we showed there. When the pressure goes up high enough, it can actually impair blood flow. So it may be that there's just not adequate blood supply to the brain, causing the problem. And that can cause, either focal symptoms, like as you're describing, speech arrest or other things. There's a wide list of things that can cause paroxysmal or intermittent neurologic problems. So seizure would be one. It doesn't sound like a seizure. It sounds like it's pressure related, but boy, it would be good to get those episodes during a time of monitoring to make sure that that's what it is.
Sure.
Yeah, that would help sort it out. Depends if they're only like 2 a year, then you're not going to get that. But if they're twice a day or twice a week, you may be able to catch it with ICP monitoring, with or without EEG monitoring, to see what the story is.
Yeah. Thank you. And this was great. Really, your whole presentation was awesome. And I like that you included the questions asked the doctors. I know a lot of people struggle with that, so I appreciate it.
Yeah, take ownership of that. That really should be, you should be empowered to push it. And if you're asking questions that are specific to your situation and are well thought out, no one should be resistant to answering them. Like if someone's not giving you due time or respect, then maybe it's not a good fit, and that's okay. I mean, just because you walked into someone's office doesn't mean they have to take care of you forever. Stylistically, you just may not fit.
Yeah, that's true. It's really big is finding the right fit. So that's really important advice. I appreciate that.
And so, there's patients along the way that certainly I've said, I've tried to explain this as best I can. Maybe it's not a good fit, and that's okay.
Yeah.
It's like dating.
Exactly. Yeah, tell me about it. But so, Dr. Harter, how can people get in touch with you if they wanted to?
I think I put it on that slide. Does anyone see that? Oh, did anyone see that last slide? That thank you slide? I think I had it on.
Yeah, you had it up.
Can you see that or no?
It just went away.
Great. That one?
There it is. That one.
So yeah. There's my email and there's my Twitter.
I found you on Twitter earlier. That was great.
There you go.
All right. Thank you so much. I'm going to try to turn my screen back on and see if I don't jump around too much. But thank you for doing this with us. It was really awesome, and I can't wait to work with you in future. I actually owe your coordinator an email back.
Yeah, really pleasure to do it, and please feel free to reach out to me if I can be of assistance with your care or the care of those you care about.
Thank you so much, Dr. Harter. Okay. Have a great night. Thanks, everyone.
Have a great night. Okay, bye.
Thank you.
Welcome.